The next session is going to be on the demand of most of our delegates. They have been asking arrange workshops on ECG and arrhythmias. This will be a special session on common arrhythmias. Because this is one subject where people fumble, they are afraid of handling an EKG, and we have with us Dr. Vanita Arora, an expert in this field. I'll request Dr. Vanita to please come on the dais. I'll request Dr. A.K. Srani and Dr. G.M. Singh to please chair this session. Both of them are general practitioners. I have specifically called to chair this session, not as specialists, but family physicians, because this subject is going to be of importance to all the family physicians. And I'll also request Vanita to be as basic as possible. Yes, please. Dr. Natrajan is already here. Please join us. आपकी information थी कि अभी तक पहुंचे नहीं. Please. Dr. Deepak Natrajan is please कुर्सी वहाँ पे दो. एक कुर्सी वाला. Dr. Deepak Natrajan, formerly HOD at Wellington Hospital, now has joined Mulchand Hospital as a full-time interventional cardiologist. He is one person who is an expert. So we have a specialist as a moderator and two family physicians moderating a session on common arrhythmias by Dr. Vanita Arora. I'll request Dr. Deepak Natrajan to introduce the speaker and start the proceedings.
Thank you, Dr. K.K. Agrawal, for calling us on the dais. Dr. Vanita Arora is a known cardiologist and doing electrophysiology, and I'll briefly read her biodata. As Dr. K.K. Agrawal has rightly said, the need of our as every physician does require ECG interpretation, and how ECG really interpretation help in arrhythmia diagnosis and number of other. We have with us Dr. G.M. Singh also as co-chairman, Dr. Natrajan. Also, I'll just briefly read the biodata of Dr. Vanita Arora. She's done MBBS MD and DMC from Ludhiana and DNB Cardiology at Scott's Heart Institute, and she has done fellowship in electrophysiology at Milwaukee, USA, and McGrillen at Germany. Earlier, she worked as faculty in Scott's and Apollo. Presently, she is senior consultant at Department of Electrophysiology, Max Heart Institute and Vascular Institutes. Over to Dr. Vanita. The time allotted is 20 minutes and 5 minutes for discussion. Thank you.
Thank you, Dr. Srani, for the kind words. Good afternoon, everybody. At this beginning, I would like to thank Dr. Agrawal for giving me the opportunity to be a part of revisiting 2009. A great year it has been. A lot of changes in the medical profession and cardiology, of course. I was told to talk on common arrhythmias, and most of the times I've seen that, when I start talking of arrhythmias, it's very boring for everybody. So I converted this into an interesting ECG session, which of course is going to be an interactive session. So the earlier you want me to be out of this place, you have to be interactive with me. It won't be a mono discourse from my side, talking, and you just listening and, just going back home. And I would say not getting the entire idea of what my talk is all about. So let's make it a very, very interactive session. I will be showing you a couple of ECGs, and please pick up those ECGs. They are very common. We see them in day-to-day basis in our clinics, in our professional life. And sometimes we pick up the right diagnosis, sometimes we do not. So let's discuss it out today. Okay, at the beginning, please let me know how many of us see the ECG every day. Please raise your hands. At least one ECG in a day. So about 20-25 people here, right? Okay. Anyway, we will be seeing a couple of ECGs today. And I always start the session by saying this very popular quote by Aristotle. We are what we repeatedly do. Excellence then is not an act but a habit. So if we keep on seeing one ECG in a day, we will see 365 ECGs in a year, and we will become good at picking up what ECG is all about. And a brief description going back to the anatomy, how is the impulse or a pulse formed in a patient, which is seen as on the electrogram. It starts from the sinoatrial node, which is seen as the P wave. Then the PR interval is constituted by the impulse going to the AV node, his bundle, right and left bundle, and to the Purkinje fibers, whereby it starts the depolarization of the ventricle, which is seen as the QRS on the ECG, and then ventricular repolarization, which is seen as the T wave on the ECG. So a simple mathematical calculation between the PQRS gives us the diagnosis what ECG is all about. Whether it is a normal sinus rhythm, a tachycardia, a bradycardia, it is a simple mathematical calculation. So this is the end of my talk, and we start with the game. Let us start the game. Please give me the rhythm on this ECG. And as per the interest of the audience, I have not included any acute MIs or any ST elevations in this. These are the arrhythmias, which means we will talk of the heartbeats, rhythm, a brady, a tachy, or a normal rhythm. So what is the rhythm on this ECG, please?
Normal.
You sure it is a normal sinus rhythm? Why do you say that? Because you see, each and every beat is preceded by a P wave. The rate is within the normal limit. So we have a normal sinus rhythm here. Okay. Now what happens here?
Ready.
Brady, yes. What brady? Yes. Okay. I agree with you. It's a bradycardia. What kind of a bradycardia? Sorry? Complete heart block. Somebody said complete heart block. Everybody agrees? This is a complete heart block? Do you see any P wave in this ECG, please? Okay, what if I show you a P wave? Please see the first beat. This is preceded by this hump. Probably this is a P wave, followed by a QRS, a T wave, and then a long pause. Then there is another QRS complex which is not preceded by a P wave. So this may be an escape rhythm. Hence, when you say bradycardia, yes, it is a bradycardia, but the sinus node has gone into an arrest. So this is a sinus arrest, whereby the sinus node after this beat has just forgotten to come back. Patient needs a pacemaker. He will present to you with symptoms of syncope or a pre-syncope, and the symptoms dramatically improve after you give this patient a pacemaker. Okay, the next ECG, please. Okay, is it a normal sinus rhythm, a bradycardia, a complete heart block? Whenever you see this kind of a box here, there is always a hint. And I have given a hint with the arrow. You see this arrow? There must be a hint. Yes? Sorry? T wave is inverted. T wave you said? Sorry? Second degree type 1 block. Somebody said about T wave. What was it on the T wave? Is this an inverted T wave? This T are you talking about? QT prolongation. Okay. What has happened to this T wave? I have shown an arrow. It must be a hint there, right? Notched T wave. Who picked up the notched T wave? Excellent. So he is right about it. The house has to agree with me. I have given this arrow here because if you see this T wave and this T wave, they are different. Agreed? If you see this T wave and this T wave, they are similar, but this is a different T wave. Probably there has been a premature atrial ectopic which has fallen on this T wave and has led on to this pause because the ventricles were refractory at that time. I told you T wave is a time when ventricles are repolarizing. That means the P wave is not going to be conducting down to the ventricles. They cannot conduct that time, right? So this is a premature atrial ectopic which has got blocked into the T wave. They have not conducted down. Whenever you have a premature atrial complex, there can be three things. One, this premature atrial complex can conduct with a shorter PR interval to the ventricles. Second, it can fall on